So the next one is medial tibial stress syndrome, and this is a tricky one. And the reason I'm going to kind of lay the story here. Normally, when you're treating somebody, you start to work on a condition or problem, and they have this much pain. And then that pain starts to come out of their calf, and now it goes into their thigh and goes towards their back. And you're thinking, we're on the right track, man. We're doing all the right stuff. When things get smaller, that's usually a good sign, especially with our nerve conditions. However, that's not necessarily the case with medial tibial stress syndrome. Unfortunately, when we have a start of a season and we have somebody who's not fully trained and they go from not being very active and being at Disney World with their parents in a water park, and they go into a basketball season or a soccer season and go an hour and a half practice 3 times a week, something has to pay the price. And when it comes to medial tibial stress syndrome, we have a couple of muscles and ligaments that unfortunately pay that price.
And a lot of times we think of this as a benign growing pain type process. There was an article not too long ago, back in 2018, that said really growing pains don't even exist, that there's no association between maturation, growth, and musculoskeletal conditions. So what we think is something very simple may not be, and shin splints is absolutely one of those things that may not be simple. Yes, it starts as a myofascial strain and some periosteal irritation and inflammation, but as that stress persists, if the bone doesn't have adequate time for recovery, we start to get a bony stress reaction, initially in the periosteum, eventually in the marrow, and then at some point in those two meet each other. And when they meet each other, now we have a stress reaction. That stress reaction then is a stress fracture. So we don't want to think of our patients with shin splints as simply having some benign growing pain. They have the start of a stress fracture, that if we don't get the formula right for getting their stresses below their body's ability to heal, it's going to become an issue with them and potentially a long-term issue. A lot of times, as you said, these kids come out of a summer where they've not been on hard surfaces, they start bouncing around on hard surfaces, and they suffer from the terrible twos: too much, too fast, too long.
It's funny, I was looking at growing pains. I never realized Leonardo DiCaprio was part of that show until I just saw that slide. And this is one of those things that if you talk to an average 9-year-old or 10-year-old, they've got to practice. They've got to be there. Their coach needs to see them. They have a tryout. They have a showcase or whatever they call them, and they try to train too much. And those are the terrible twos. That unfortunately, your tissue has only so much capacity and only so much capacity to get better. Meaning, if we gave Dr. Berlesman some bicep curls, 20 years ago, today, then unfortunately, after he does those exercises, he does them for 1 month, it's still not going to be overly excessively big. As a young athlete, we can start to see that our muscles and ligaments grow faster than other tissues. So something will pay the price. And unfortunately, when we start to pay that price, it has to do with a couple of risk factors. The position of the actual foot. Are we getting a twisting motion of that foot? And then, of course, BMI, because everything we talked about, hard surfaces, doing too much training is based on ground reactive forces. So if I have a muscle that's only so strong and I put on 10 pounds as a child, which as a child is a big deal, when they're starting to grow, they're putting on a lot of weight, their center of gravity is changing, then unfortunately something has to pay the price. And we see that flexor digitorum longus and posterior tibialis pay the price, because those are the muscles that have to take a very mobile adapter of a foot and turn it into a stiff, rigid lever as you push off. We think of them as the ones that hold the foot, hold the arch, but really they're creating that lever to propel that person forward. And if you're having to move a little more weight forward, that can cause a big deal. Now, if it's just a muscular problem, if it's just the muscles that are causing the problem, we can probably hypothesize that when you start to use those muscles, it's going to get worse. So if it's truly a muscle problem, it's worse when you get started. But you've had those patients with a muscle or tendon problem. After you start to use it, it starts to get maybe a little bit better. They make it through practice. They make it through their game. But unfortunately, this progressively gets worse. It gets more and more sore as we go through the games or go through our season, and it starts to become bigger. I mean, the whole muscle at its insertion on the periosteum gets irritated, and unfortunately, you can even rub that area. You're starting to see inflammatory nodules right along that bony ridge, right along the medial aspect of that tibia, and you can feel the tenderness, you can feel the soreness that person's having, and this wide range of symptoms.
And one of the things to recognize is, as you said initially, usually that is going to be at least 5 centimeters long. It's going to be a pulling of the periosteum over a long distance. As we start to see that area of tenderness shrink, that's a bad sign. Think of if you had a piece of paper and there were stretch sensors all along the top of the paper. When I pull on that, each of those stretch sensors or pain sensors is going to be triggered. But if that paper now tears, when I pull on it, only a very small chunk of those stretch receptors are now being triggered. The ones on each side of that tear are no longer getting a disproportionate amount of pull. And so now we have a shrinkage of that pain. And when that pain shrinks down to a very small part, we're suspicious of a stress fracture. It starts with a periosteal inflammation here is grade 1, starts to get into the marrow in grade 2 and 3, and then those two areas start to marry each other where the inflammation moves into the cortex, and now we develop a line which tells us now there's a stress fracture. So when somebody has diffuse tenderness at the start of activity over a long insertion of the flexor digitorum and the tibialis posterior, not overly concerning, but it's a precursor for what's about to happen, that it's going to become more focal over time. It's going to persist more than just the first 5 minutes of activity. The tibia is going to be very tender. There's going to be swelling. Maybe you put a tuning fork on there and the vibration hurts. It hurts for them to hop, and it hurts for you to bump that tibia, which is the next thing we'll cover, I think, tests.
Yeah, I'm not a big fan of just randomly going through there. I'm a chiropractor. Let's get in there and move some stuff. So a Taylor bump test is going to light that up every single time. It's kind of doing a drop arm sign. Once you think someone has a tear in the supraspinatus, just drop their arm and you can really make sure right away.
That'll make for a happy patient.
Very happy.
Another happy patient is if you squeeze their leg and it's particularly tender. The one other red flag that we want to look for in lower extremity pain is the possibility of a compartment syndrome. So this means that there's been pressure within that fascial compartment. That fascial compartment now is starting to compress the vessels. But what it's going to compress first is the vein, because the vein operates at a lower pressure. The artery still pumps blood in, but the vein can't pump it out. Like getting your finger stuck in a soda bottle. Arterial pressure is going to still force blood through, and your finger is now really going to be stuck. As that continues, something's going to be squeezed, and something's going to pass out and then die. The symptoms of that passing out and dying can look like shin splints sometimes, but ultimately it turns into much more significant pain that increases dramatically with activity. Sometimes these kids have to have surgery to release that fascial restriction and adhesion to allow the compartment to have a little bit more space. But one thing that we don't want to miss is the signs of a compartment syndrome. Is there any cyanosis? Is there any diminution in pulse? Is the pain increasing just proportionately in an ischemic type reaction throughout activity? So we don't want to miss that.
Yeah, just think about it, the fascia doesn't grow as fast as the muscles. And unfortunately, those muscles can gain size and girth. The fascia needs a little bit of time. So I'm going to jump into actually this. We'll just go ahead and show this. So medial tibial stress syndrome, what you can do is go in right here and go into ChiroUp and just go into the clinical skills section. Drop down a condition reference. You can go through all the evaluations and isolations and exercise if you want to do that. However, I just normally go by condition. And if I type in medial, it's going to pull up any condition with medial in its name. So now if you spell it right, you'll probably get a better result. I think medial is with an A, not an E. Is that right? I'm from Missouri. Give me a little bit of slack.
Not a whole lot. For the show me stage, show me you know how to spell and I'll be really impressed.
Exactly.
So MEDIAL is
right here, and medial tibial stress syndrome. Here we go. So what this is going to do is allow you to see all the evaluations. So if you want to learn about the Taylor bump test, just like we showed, you can actually click on here. It's going to show you with sound of exactly what the Taylor bump test, along with the single leg hop test. Let's go. I mean, obviously you guys can probably think about what that would be, but you're going to stand and you're going to jump on one foot. Now think about this, is that someone who's in a lot of pain is probably going to land with a little bit of plantar flexion of their foot and soften that blow. So if you really want to test for a stress fracture, go ahead and let them land on their heel and you'll be able to get a better assessment for that. You can also go through here and look at the management. Now remember, whenever you see STM, that's soft tissue manipulation. If you want to look at soft tissue manipulation, let's say the tibialis posterior, you can get how to exactly do that. You can also get on here where the muscle is, and anytime you see an X on there, that's where it's going to show exactly where the trigger points are per Travell and Simmons. So things to think about as far as, what's in your toolbox and how can you expand that toolbox. Finally, I think the hardest part of this is piecing that together. So when I have someone with medial tibial stress syndrome, yes, I know what to do in office, and maybe I can give them the right kind of education, but ChiroUp remembers those exercises. So if you need to know how to do a soleus stretch, the muscles that are going over the front are the back of the foot. If you want to do anterior tibialis stretch, you can now give people exercises with printed versions and also video versions of exactly how to do each one of these exercises. And that's not just right here. It doesn't just live right here in ChiroUp. They actually get an app and the ability to see their exercises with your logo and your name on there. So it's something kind of neat that once you create your condition report, and we'll do that with Seaver's disease, that you can actually now deliver this to your patients and have the ability to give them the best information. If you want to go back and fact check us, which I would highly recommend doing, because it's kind of late on a Friday here, things get a little foggy. You can actually go on Introduction to Etiology. You can learn more about the clinical presentation. Essentially, where do we get all our information from? Everything's referenced, and the ability to go back and just learn a little bit more about a condition from there.
Yeah, that's excellent. So hopefully you'll see this webinar as part one of what we're trying to accomplish to show you the best practice management of what's known about these three conditions. So you'll have access to the QR code that was on the screen. You'll be able to access ChiroUp, go in and check out any of those tests like these, the single leg hop test, which is going to tell us, is there a problem? But more importantly, this talar bump test, that the talar bump test, a single leg hop is going to hurt if the patient has most anything wrong with the muscle or the bone. So they could have a stress fracture or they could have traction periosteitis. It's probably going to hurt. Whereas a talar bump test is not going to hurt the muscle so much. It's going to tell us, oh, there's something wrong with the bone. And it'll also help us to determine, is imaging appropriate? If somebody has a positive talar bump test, if they have any red flags, or if they have a focal tenderness that's not at least 5 centimeters, pain that persists at rest, or you've treated them a couple of times and they're not feeling better, we image them. And when we image them, we're looking for a couple of different things. Number one, is there sclerosis? Number two, is there some elevation of that periosteum? Is the cortex beginning to thin? Or most significantly, which is a dead giveaway, is there a fracture line? And in those cases, now the patient needs rest as opposed to having some options in the past. One of the things that you'll be able to check out when you go into ChiroUp is all of the soft tissue work. So we'll work the tibialis posterior, the tibialis anterior, the gastroc and soleus, which are so important in all these lower chain problems. And then we're going to give that patient some home exercises. Stretch out the gastroc, stretch out their hamstring, strengthen the posterior tibialis. If you're not using that one with the red band, that's a game changer for a lot of lower extremity conditions. It's basically allowing the patient to develop strength in the muscles that can help get them away from using an orthotic, and then some core stability, and most importantly, giving them the advice of how to get back to activity in a wise fashion. They don't have to stop activity most of the time unless there's a stress fracture, but we have to modify that. They have to have selective rest to make sure we bring the stress down below the body's ability to heal, the bone's ability to heal. Most of the time, that's the 10% rule. We see so many patients because they broke the 10% rule. They sat around at a desk all week long, and then they went out and ran a 5K with their kids on the weekend, and their body wasn't ready for that. So we want to make sure that they increase their activity slowly, first with distance and then pace. For our patients with bony problems, we want to get them off real hard surfaces, especially unlevel surfaces. And then the running mechanics is a big thing too, as far as how they're hitting the ground.
Yeah, two things with running. What we know with running is if you can widen your stance phase, it will significantly help with that frontal plane alignment, the knee, the foot, and also the hip. So that's the first thing, is to have a little bit of a separation while you're in stance phase. Don't run on a balance beam, essentially. The second is to increase your cadence. Take more steps. Those longer steps increase ground reactive forces that have to be dissipated somewhere. And unfortunately, when you have somebody that's getting any kind of a twisting motion or they're getting too much of a frontal plane motion, that's when we're going to see irritation within the tibialis posterior and the flexor digitorum. And finally, shoes. So many people buy their shoes from department stores or online. They need to be fitted for shoes. There are certain types of shoes called motion control shoes versus neutral shoes versus stability shoes. And getting somebody in the right type of shoe will help. Going from a shoe with a high ramp angle to a zero drop shoe, going from a minimalist shoe to a New Balance shoe. We need to make sure that we understand what kind of shoe the person's in and maybe there's a better type of shoe, and maybe you're not the expert on that. That's fine. Find a running store in your area that can be your partner with these patients. Say, listen, I'm not sure what's going on here. Did a gated evaluation. I've done everything I can. Let's take a look at their shoes. The more people you can find that believe what you believe, which in this case is to help get people out of pain, the more times you're going to have a bigger reach and more referral network. So here's a couple clinical pearls. One thing is I really think that just to determine, is this truly a stress fracture, which is it's a stop sign, unfortunately. We need to let that tissue heal, or just the beginnings of a stress reaction. If that's the case, we can solve this with some good patient education, parent education, I think is what we should call it. Maybe we should do that. Have patient education, also the parent education.
I'll stick with the patient. You can go with the parents.
And then to determine what to do about it. And remember, just because you can tear it down and you can calm it down doesn't mean that your job is done. Make sure you build it back up.